It's a pleasure to be here and talk to you about incidental non-functioning pituitary adenomas, surgery or observation. I'm Maria Fleseriu. I'm a professor of medicine and neurological surgery, the director of the Pituitary Center at Oregon Health and Science University in Portland, Oregon. The learning objectives for today are to identify possible presentation of a pituitary incidentaloma, and there are many, and you'll see, recognize the differential diagnosis, and explain when surgery is indicated versus observation, and this is more complicated than it seems, and we need individualized treatment. So let's start with a case. A 60-year-old woman underwent brain MRI for investigation of chronic headaches, and as we know, the headache is very frequent in general population. And as you can see here on the right, a 1 centimeter pituitary mass was discovered, and the radiology report concluded that the mass is either a cystic adenoma or a Radke's cleft cyst. And you see here that cystic component, which again, most likely looks like an adenoma to me, but could be a Radke's cleft cyst. What are the next steps? Is this an incidentaloma? And what is the differential diagnosis? Because headaches is, as I said, very, very frequent. This was a brain MRI. Do we need a dedicated pituitary MRI? What initial evaluation is warranted? What follow-up is indicated? Do we need surgery or not? And what's the patient's impact of a pituitary incidentaloma diagnosis? And as you see, all these questions are very, very important. And in a short presentation, I'm not going to be able to talk about all of them, but I wanted you to remember that this should be the frame that we process every diagnosis of a pituitary incidentaloma. So the differential diagnosis of a cellular mass is huge. And this is from a paper in 2021. We have slightly updated in the guidelines that I'm going to present you more. But largely, 90% of the pituitary incidentaloma are pituitary adenomas. However, 90% is not everything. So I want you to remember that could be cystic lesions, could be vascular, could be inflammatory, could be also other type of tumor from craniopharyngioma. I mean, angioma is extremely rare, but they could exist, metastasis, and of course, infections in some areas of the world are more frequent than in others. And actually for small lesions, the one I showed you, could be technical artifacts. So that's very important not to assume this is a pituitary adenoma. However, if it is a pituitary adenoma, in our mind, we should answer even more questions. In the WHO classification from 2022, recommended to classify the tumors based on adenohypophyseal cell lineage. And I'm going to show you why. Because yes, functioning or non-functioning means what are the hormones in the blood. But to really know the type of tumor, we need to look not just at the hormonal staining, but also at the lineage of the subtype of pituitary adenomas. And why? Because as you can see, microadenoma, it's easy. It's a small, tiny lesion. Macro, it's anything over 1 centimeter. But what type of cell lineage they are, it's important for the prognosis. And as you can see here, the PIT1 are lactotroph, mammosomatotrophs, somatotroph, or thyrotroph. So this is important to think about what type of tumors they are for the prognosis. And now I will switch a little bit gears and talk more about the pituitary incidentalomas that we established that we have to figure out first that this is a pituitary adenoma, and then what type of pituitary adenoma if we find an incidentaloma. But once we find that incidentaloma, we need to know what type it is. So if we think this is a pituitary adenoma, or even if it's not, we need to have a full hormonal evaluation. And that's why us neuroendocrinologists are so busy. We have to check at baseline for prolactin and IGF-1 in all patients with an incidentally discovered pituitary adenoma. And then screening for hypercortisolism should be performed if clinically warranted. Now, how to check for all these hormones? We have recently reviewed in this paper that I have mentioned here, hypopituitarism in a Lancet paper. I wanted to remind you that for hyperfunctioning, IGF-1 and prolactin in everybody, and screening for Cushing's in patients that have some clinical features. However, for low hormones, we need to check a full panel because any type of lesion, sometimes even smaller pituitary adenomas or smaller cysts, can induce pituitary dysfunction. So we need a full pituitary panel for low, and then, of course, prolactin and IGF-1 in everybody for high. Now, why are we talking about this? We found here, for example, in this patient, a very small microadenoma. At that point, we were not even sure in the dynamic view if it was an artifact or not, grew over time and grew even more. So microadenoma can grow. So that's important to remember. Some could also shrink, and you see here in this patient also shrinkage. And this is very important when we decide when to do the next imaging. As you know, non-functioning pituitary adenomas are not all of them incidentaloma. However, the literature overlap because these are the adenomas that do not go to surgery all the time, and we'll see when they need to go surgery. This is our study that included a large patient population. 271 patients had follow-up imaging for 29 months with a big range, as you can see, and 8% grew. Now, the gross incidence was 2.1 per 100 years, and the median time, as you can see, was not a year like we used to do before MRIs every year. And what was more important, the tumor growth was mild and not associated with new pituitary dysfunctions. This was for microadenomas. This does not apply to macroadenomas. And the mean time to growth was shorter in patients that were over 65. This has been also shown in a UK large multi-center study. And you see on the left, this is a cumulative probability of non-functioning pituitary adenoma. So you can see growth-free survival that several of them will grow, but not a lot. But also, this is the reduction-free survival that some will actually shrink. So it's important to know what's happening to these adenomas before we make a diagnosis. So what we have recommended, and I had updated here in this graph, for pituitary incidentaloma is pituitary function testing at presentation and during follow-up. If it's gross and no symptoms, then we need to do it again in every 2 years. And of course, if it's gross, we have to do it probably more frequent. Individualized treatment is key. How about pituitary MRI? For microadenoma, this is the big change compared with the recommendations before, after 2 to 3 years, because us and others have shown that these are slowly growing, and not all of them will grow, some will actually shrink. And then, of course, if the lesion is very small, we need to stop at some point. But in the meeting, this was a large interdisciplinary group. We could not agree when to stop it. So, for example, I do another one if it's stable and then stop it, and also individualized by the age of the patient. Now, if it's a macroadenoma, that is becoming more complicated. If it's very close to the optic chiasm, I do after 6 to 12 months. If it's not, I do a year. However, that also depends on the patient anxiety about this. And then for visual field testing, that also depends on where the adenoma is. Because you see here, if it's suprasellar extension and it's not even close to it, besides the baseline, I would do a repeat at 6 months. If it's farther away, I do repeat 1 to 2 years. And sometimes I'm changing not to be in the same year with the MRI if we're extending the MRI just to have some follow-up. So when is surgical resection indicated? Because this is a question that the patients are asking when we see them. I have a pituitary adenoma. It seems like it's not functioning, doctor. Do I need surgery or not? So what we recommended is if it's hypersecreting, then yes, we'll go back to the guidelines for each of the tumors, and patients will need surgery or not need surgery depending on the type of adenoma. In patients with visual compromise, cranial neuropathy, or other neurological deficit, again, that's recommended surgery. Recommend surgery in patients with an adenoma that is very close to the optic chiasm. And here we went back and forth because we want the patient to have surgery if it's possible in a center of excellence, because then the risk of hypopit and other complications is lower. However, in patients that are older, if it's just close to the optic chiasm, maybe waiting a little bit, observation can be considered if it's a poor functional status, and we know the surgery will have more complications. How about surgery for patients with severe and more progressive vision loss? Depending for the pituitary apoplexy, there are studies now, so that's why you see here suggest, not recommend, that high-dose steroids in an acute situation would have the same outcome as surgery. So that depends if the severe, that's a key, and progressive vision loss, then surgery is recommended. Otherwise, could be other treatment. Now, also the issue of headache. I told you we'll come back to headache. We suggested risk and benefits of surgery to be considered if the patients have severe headache. In this patient that I showed first, we don't know if the headache is due to this cystic lesion. And also, we don't know if it was treated medically or not. So what we have suggested is the headache, if it's refractory to all the anti-headache medication, to have the patient evaluated in a multidisciplinary clinic. We always send the patients to an expert neurologist. And if still the patient has headache, then we suggest that possible surgery for that lesion could be considered depending on the patient. And now the key question is that we don't have a real answer is if the adenoma is more than 5 millimeters from the optic chiasm, we suggested individualized care because the age of the patient, as I mentioned earlier, and also where the mass is and how it looks, it's also important, but we always consider surgical consultation. And then if we see that the adenoma is growing over time, or in women desiring pregnancy, when we know that the normal pituitary is increasing 30%, for example, volume-wise, and then the adenoma can actually push on the optic chiasm and so on, we suggest the patient to see the surgeon. However, keep in mind that the surgery could have also minimal but risk of hypopit even in the best hands. So for women desiring pregnancy, this is a very important decision that we have to make. And again, individualized recommendations are key. So we tried in the guidelines to talk about between recommend and suggest, and this is based on data and personal opinion of experts. However, this is very more important to think this as a conversation between who's in the room with a patient. So for asymptomatic macroadenoma, again, we suggest considering age and functioning, deciding between surgery and observation. And if it's a frail patient, close observation is good too, unless the patient is actively losing vision, but this is, again, asymptomatic. For progressively enlarging macroadenomas, especially close to optic chiasm and for patients with new onset hypopituitarism. But keep in mind, and I always tell the patients, the fact that you develop new pituitary dysfunction is probably due to the enlarging mass. However, that doesn't mean that they will recover. Some will, but also can get worse post-surgery. So this is something that we need to also think about. So in summary of this very short talk, I showed you that pituitary incidentalomas are frequent, between 10 and 38% of adults and 2% of children on imaging. Population-based study indicate a prevalence of 22 per 100,000 years and an increasing incidence. And most pituitary incidentalomas are small, and I showed you some can grow, some can get smaller and correspond either to non-functioning adenomas or Rutgers cleft cyst, but the differential diagnosis is big, as you've seen. The initial biochemical testing, we have to rule out hypopituitarism with a full pituitary panel and then repeat as needed, as I showed you, based on individual characteristics. Rule out hypersecreting adenomas, a measure of prolactin and IGF-1 levels in all incidentalomas to make sure that we're not missing prolactinomas, but also not missing acromegaly. And then when we have high prolactin, think about other causes. And we didn't discuss in detail that not every high prolactin is actually prolactinoma. And also, the final recommendations, not all pituitary adenomas need surgery or medical treatment. Observation is sometimes better. And with that, I wanted to thank all of you for listening to this very short brief review of non-functioning pituitary adenomas found incidentally. Thank you so much.